In the following video, we will discuss the surgical nuances in management of intraocular cysticercosis. Our first patient is a 56-year-old who presented with history of seizures and on neuroimaging was diagnosed with neurocysticercosis. Dilated fundus examination of his right eye revealed the following picture. 25 gauge pars plana vitrectomy was performed. Anterior, port site and core vitrectomy was done. During core vitrectomy, something peculiar was noticed. It was a live subretinal cyst as suggested by its movements. Diathermy over the temporal aspect of the cyst was done and careful extraction of the subretinal cyst was attempted. With patient and gentle movements, the intact subretinal cyst was brought into the vitreous cavity. Quick aspiration of the cyst was done by the vitreous cutter. Fluid air exchange was done. Laser was done to the retinotomy through which the cyst was extracted. On postoperative day 10, the patient had attached retina with macular scarring. Our second case is the left eye of the same patient. 25 gauge pars plana vitrectomy was done and a PVD was induced. Extension of the PVD was done with the dead subretinal cyst visible along the inferotemporal arcade. As the cyst was fibrotic and adherent to the overlying retina, an ILM forceps was used to extract it. High vacuum was used in the vitreous cutter to quickly extract the dead fibrotic cyst. Following fluid air exchange, laser was performed around the area from which the cyst was extruded. On postoperative day 10, the retina was well attached with scarring beyond the inferotemporal arcade. Our final case is a 38-year-old lady who presented with vitreous cyst and vitritis in her right eye. 25 gauge pars plana vitrectomy was done. Core vitrectomy was done. Vitreous membranes overlying the area of cyst extrusion were removed. Quick aspiration of the vitreous cyst was done using the cutter. Removal of vitreous and inflammatory membrane from the posterior bowl as well as the area supratemporal to the arcade was done. Aspiration of any stray inflammatory exudates were done using a soft silicone tip. Following air fluid exchange, laser along the supratemporal area was done. On postoperative day 14, the retina was well attached with scarring along the supratemporal arcade. In conclusion, pars plana vitrectomy is safe even in live cysticercosis cyst. 25 gauge MIVS system can be used to aspirate even dead fibrotic cysticercosis cyst. Patience is the key in subretinal cyst to ensure the retinotomy does not extend. Vitreous membranes may be adherent at the site of cyst extrusion and must be removed.